Welcome to the Understanding MIPS Reporting Options conference call. My name is James, and I'll be your operator for today's call. At this time, all participants are in a listen-only mode. Later, we will conduct a question-and-answer session. During the question-and-answer session, if you have a question, please press *1 on your touch-tone phone. And I'd now like to turn the call over to Sarah Brinkman. Sarah, you may begin.
Thank you, James. Hello, everyone, and welcome to our webinar, Understanding Merit-Based Incentive Payment System Reporting Options. We're so glad that you joined us today. My name is Sarah Brinkman, and I'm a Program Manager for the Lake Superior Quality Innovation Network, which serves healthcare providers in Minnesota, Wisconsin, and Michigan. Before we jump in, let's address just a few housekeeping items. Those of you who registered before today should have received a reminder, including a link to the webinar event page, where you can find the handouts for today's presentation. We'll be posting that link in the chat box as well. A recording of today's webinar will be made available in a couple of weeks, and you'll be able to find a direct link to that recording from the event page. We encourage you to ask questions throughout the presentation utilizing the chat function, and we will address your questions throughout, as well as open up the lines for folks to questions to share over the phone as well. Finally, when you close out of today's webinar, you'll be automatically redirected to a short evaluation. We greatly appreciate you taking a few minutes to provide us with feedback, which we'll use to inform our future educational offerings. And upon completing the evaluation, you'll receive a certificate of attendance for your records. With that, I'd like to turn things over to our presenters, Candy Hanson and Lisa Gall.
Hi, thanks so much, Sarah. Welcome, everyone, to our webinar, Understanding Merit-Based Incentive Payment System Reporting Options. I'm Candy Hanson. I'm a Program Manager for Stratis Health. I'm a nurse by trade, and I am one of the subject matter experts for the Quality Payment Program here in Minnesota at Stratis Health. Lisa?
Hi, my name is Lisa Gall. I've been an RN for 18 years and a nurse practitioner for 14 years in family practice, urgent care, and ER. I am also one of the subject matter experts in the Quality Payment Program at Stratis Health.
Next slide. We include a disclaimer to all of our slide decks now, and mostly we do this just to acknowledge that the information we are presenting is based on our most current knowledge of the interpretation of the CMS final rule for the Quality Payment Program. We encourage everybody to stay engaged with the QPP portal as they do post new resources frequently, and sometimes we don't get notice of those. So just keep yourself current there. That's where you're going to find your most current information. Next slide. In case you aren't familiar with the Lake Superior Innovation Network, or the LS-QIN, we are the three quality improvement organizations of MPRO in Michigan, Stratis Health in Minnesota, Medistar in Wisconsin. And we collaborate to improve health for Medicare consumers, share best practices, and maximize efficiencies. Next slide. Today we want to help you understand the pros and cons of group versus individual reporting for the Merit-Based Incentive Payment System, or MIPS, review the available MIPS data submission methods, and help you identify considerations for selecting the data submission method that will benefit your practice for the most for the 2017 transition year. Next slide. For today's presentation, we're only going to provide you a very high-level overview of the Quality Payment Program. We are making an assumption today that you already have a basic understanding of the program. We do, however, acknowledge that from feedback we've received in the past that there are those who still consider themselves to be just at the beginning of understanding the QPP program. We have all of our webinars recorded on our LS-QIN website, but more importantly, if you go to the LS-QIN website and you click on the Quality Payment Program and then click on the resources on the left side of the screen, you will see a resource page on our website that contains a very robust set of YouTubes and other resources for getting a basic understanding of the QPP. And they're put together, they're designed not to be the hour-long recorded webinars. We've taken them from CMS's site, as well as other documents. So we encourage you to go to that resource page to get yourself up to speed on the Merit-Based Incentive Payment Program as well as QPP in general. Next slide. In the Quality Payment Program, there are two tracks for eligible clinicians. The first path being the Advanced Alternative Payment Model. CMS is expecting that only 7 to 8% of clinicians fall into that category for the 2017 transition year. If you are a qualified professional in an Advanced Alternative Payment Model, you are eligible for a 5% Medicare fee-for-service bonus for the next 5 years. The second path that CMS is expecting 90+% of clinicians to be eligible for is the Merit-Based Incentive Payment System, or MIPS. If you are a MIPS-eligible clinician, you are eligible for a positive or negative payment adjustment that is budget neutral. In addition to that, if your score is 70 and above, you are also eligible for a portion of the $500 million Exceptional Care bonus payment for the next several years. Next slide. This screen just shows the four categories of MIPS, which each contribute a certain weight to your MIPS score. Your MIPS score is based on the performance year and impacts your payment 2 years later for the Medicare Part B fee-for-service schedule. For 2017 performance year, quality accounts for 60% of the MIPS score, or 60 points. The Advancing Care Information category accounts for 25% of your MIPS score, or 25 points. And then there's a new category of improvement activities that accounts for 15% of your score, or 15 points. For the 2017 transition years, cost accounts for 0% of your score, but it will be phased in future years. All right, Lisa, do you want to take us through the group versus individual reporting?
Yes, thanks, Candy. So we'll talk about the differences between group versus individual reporting. Next slide, please. CMS defines a group as a single tax ID number, or TIN, with 2 or more clinicians, one of which must be a MIPS-eligible clinician as identified by their NPI, or National Provider Identification. The MIPS-eligible clinicians include these 5 clinicians listed. Eligible clinicians must also reassign their Medicare billing rights to the tax ID number and maintain their group status for the whole reporting period. The group or organization on behalf of the group collectively decides if they will report as a group or as individuals. If they decide to report as a group, all eligible clinician types must participate, including those who do not exceed the low volume threshold at the individual reporting level. The reason is that as a group, all clinicians collectively exceed the low volume threshold, or they do not. The group performance in the 4th bullet is assessed and scored as a group for all 4 MIPS categories. So, 2 points. You must include the MIPS-eligible clinicians, including those below the low volume threshold, and you could include items and services furnished by excluded eligible clinicians. I'll go over those excluded eligible clinicians in the next slides. You will receive 1 MIPS payment adjustment as a group, but that would apply differently at the group level in relation to each exclusion circumstance. So the payment adjustment only applies to groups MIPS eligible clinicians and does not apply to clinicians excluded from MIPS based on those exclusions. So this slide shows the clinicians that are exempt from MIPS, and they fall under 2 categories. Those that are determined at the individual NPI level include 2 types: new Medicare enrolled clinicians, and in the first year of practice, and the qualified professionals, or QPs, and partially qualified professionals, or partial QPs, who do not report to MIPS under an advanced alternative payment model. The second group of MIPS-exempt clinicians is the low-volume threshold. The low-volume threshold is determined first at the individual TIN NPI threshold for individuals, and then at the TIN level only for groups. And as I said before, the MIPS payment adjustment would apply differently at the group in relation to each of those exclusion circumstances. Next slide, thank you. The group reporting has some specific nuances. So if you are reporting as a group, all eligible clinician types must participate. The newly enrolled Medicare clinicians and QPs who do not report will not incur payment adjustments, and partial QPs can choose whether they would like a payment adjustment, and that is done at the entity level of the advanced alternative payment model. The individual clinicians who are not required to participate in group reporting include voluntary reporters such as therapists, dietitians, counselors. The new Medicare clinicians and partial QPs will not receive payment adjustments. Next slide, please. If a MIPS eligible clinician reports as a group and as an individual, CMS will calculate a final score for the group and individual identifier and use the highest final score for the tax ID number MPI combination. So each tax ID number MPI will receive only one final score for the purpose of the MIPS payment adjustment determination. And third, CMS allows each MIPS eligible clinician to decide how they want to report, either individually, through a group, or through an APM as a MIPS APM participant. And finally, CMS cannot really completely control the number of submissions that one tax ID number and NPI may have. So the highest score will be applied to each clinician. Next slide, to recap. No non-eligible clinician types include therapists, dietitians, counselors, new Medicare clinicians, qualified participants, and partially qualified participants in APMs. They are not required to participate in MIPS. They can report voluntarily to contribute positively to the group score. They will not receive a payment adjustment. And another benefit is the opportunity to practice in the quality payment program so that you're at the top of your game when you're eligible to report in 2019. Next slide. For clinicians practicing in multiple settings, the low volume threshold is calculated for each individual clinician at the NPI associated with each practice, or tax ID number. Therefore, the low volume threshold will be calculated for each practice associated with the clinician at the TIN NPI level, at both the individual and the group level. And third, eligible clinicians types are required to participate in MIPS for each practice, TIN NPI numbers that they are associated with, unless the clinician does not exceed the low volume threshold for a particular practice and that practice does not report as a group. This slide shows the differences and the benefits between individual and group reporting. So based on the score for individual reporting is based on individual performance, but in group, it is aggregated for all clinicians. In individual, the solo practice, you might decide to report as an individual if you are a solo practice or you did not maintain group status for the whole reporting period. And you might decide to report as a group if you have a large number of clinicians that you just want to make it easier to report. For individuals, the individual MIPS scores, you might decide to report individually if your MIPS score is higher than the group composite score. So your group decides to report as a group and your individual score is higher, you can still report as an individual as well. And you might consider group reporting if individual MIPS scores are lower than the group composite score. And the fourth bullet is that CMS will take the higher of your group versus individual scores if you report both ways. But remember that clinicians with lower performance or measures not applicable to practice may actually decrease the overall group score. In individual reporting, you compare your scores with all MIPS-eligible clinicians and voluntary reporters. And in group reporting, you compare your scores with all MIPS-eligible clinicians and voluntary reporters so that clinicians with higher performance may increase the overall group score. The final difference is in individual reporting is that each individual needs to meet both the ACI, Advancing Care Information Category base score, and performance improvement activities. But in group reporting, only one clinician in the group needs to meet the ACI base score and perform the improvement activities. At this point, we're going to take a pause and ask if there are any questions.
James, would you remind our audience how to open up their telephone lines if they have a question?
Sure. If you have a question, please press *1 on your touchtone phone. If you wish to be removed from the question queue, press the # sign with the # key. If you're using a speakerphone, you may need to pick up the handset first before pressing the numbers. Once again, if you have a question, press *1 on your phone, and we do have a question from Mandy Cherry.
Hi, this is Randy, and I do have a question. If I belong to an ACO and my score gets consolidated at a group level, can I additionally then submit my individual score and CMS will look at the higher of those two scores? Or when you're talking about group submission, are you not talking about the ACO group submission?
That's a really good question, Cherry. And I think we need to do a little more investigation. Most of what we're talking about now has to do with individual or group with outside of an advanced APM entity. So I think with the advanced APM entity, I believe you only have one option in advanced APM is the group report.
This is not an advanced APM. This is an ACO. This is a MIPS APM, not an advanced ACO.
Got it. Okay, so for the MIPS APMs, I do believe they also still need to report as a group, but I would like to have that question verified with CMS. Anyone else have, Candy, do you have any further information on that one?
No, I think what Randy is describing is correct in how I'm interpreting it, and how I'm interpreting when CMS is taking the higher of the two scores. But again, Lisa, it's always worth verifying.
I'm sorry, I was going to say it's not going to hurt to have that individual do individual reporting in case they do have a higher individual score, so that individual score carries with them if they move on to another organization.
Well, yeah, I mean, that's a really pivotal question because we've been going along all along thinking, oh, we're only going to submit as the group and our scores are not going to be nearly as good as if we submit individually. And so we haven't been under the auspice to submit individually. And I have another question. If a lot of our providers work both at an ambulatory and a hospital setting, surgeons and cardiologists and OB-GYNs and stuff like that, and so there's two different EHRs. So if I submit my quality measures from both locations, is CMS going to take the better of the two? Because they haven't answered that question. We've asked CMS that question, and we never get an answer.
Are they out of a different TINs, Randy, or is it out of the same tax identification number?
Well, this would be submitting individually, and it's under the same TIN. So a cardiologist works at their office and they have NextGen. They go over to the hospital and they work at the hospital, and that's Cerner. So there's quality measures from Cerner. There's quality measures from NextGen. We cannot get an answer whether you're going to combine those two, whether you're going to take the better of the two, whether we should only submit the best of the two, whether we should submit the one that has more than 50%, even though,
You know, for advancing care information, let me try to attempt to answer this one. For advancing care information categories, as long as you include more than 50% of all patients seen, you can choose one or the other of those numerators and denominators measures for advancing care information. And in fact, the same applies true for quality. As long as it's over 50% of all your billed visits, you can exclude one of those sites as long as that site is not exceeding 50% of your billable services.
So you're saying I can exclude them. Can I? So let's say I have a cardiologist that's 60% at the hospital and 40% at the practice. I have to submit my quality measures from the hospital and not from the office.
Yes, you can do that. The other option would be to get a data submission vendor to combine the two, or you can manually add the numbers for your advancing care information. Where it gets a little trickier is the quality information because those need to be submitted electronically.
Well, yeah, so each of our EHR vendors is saying, yeah, I'll submit your quality, I'll submit your quality. So there's going to be two sets of quality data going into CMS.
And I think, I don't know that we've gotten a clear answer from CMS on that as well. If they both submit, we don't know. They'll probably end up combining it.
Could you try to get those two answers if you can?
We can still try to continue to get those answers, but yes, I think CMS is struggling with the answers themselves. So I think we need to move on because we've got a lot to cover yet. Sarah, is there anything in chat that we can quickly answer?
I'm not seeing anything in chat at this time.
Okay, so I'm going to keep going then, and so I'm going to start to talk to review the data submission method for 2017 then. So next slide, please. In general, you'll be reporting to the 3 of the 4 categories for 2017. You can report using different submission methods for each of the categories if you would choose to, if you would want to, but you can only use one submission method per category. Next slide. So here are the quality measure submission methods. Haven't changed. Claims is individual only, electronic health record, qualified registry, qualified clinical data registry. If you're a group of 25 or more, you can submit using the CMS web interface, and then you can also use your CAP for MIPS to help with your quality submission requirements. Next slide. So we'll start with quality. It's showing administrative claims here as counting towards one measure, and administrative claims is not something that you'll actually be reporting. It's calculated from adjudicated claims. There are actually more than 243 measures for qualified registry and qualified clinical data registry. If you have gone into the quality measures in the QPP portal recently, you'll see that they've added some of the CAP for MIPS measures and some others. CMS does say in the final rule that and in communications that they are trying to increase the number of measures reported by the EHR method. You will note that claims is not on this slide, but of course claims are allowed for 2017, and there are a lot of measures that can be supported by claims currently. However, CMS does tell us in the final rule that they are trying to move away from claims as much as possible and push people towards especially towards qualified clinical data registry. And you will note in the claims, if you look at the benchmarks for claims, sometimes they are lower than the other submission methods, so you end up not being able to score as high. And this graphic is just taken from the group reporting resource from the QPP portal. Next slide. So individuals for quality again, this is just to recap that individuals can report using these methodologies or these data submission methods, and groups is pretty similar, except they have CMS web interface for groups of 25 or more, and CAP for MIPS survey as well. Next slide. So for the claims, for the data submission method, for claims, you can only report claims as an individual. You select your quality measures and begin reporting through the routine billing processes. You can report more than one measure with a single claim. We encourage you to check with your vendor to see if they've already mapped the appropriate CPT codes to your claims in your EHR if you're using one. Just to note that specifications may be different for the same measure using a different submission method. Benchmarks, as I just mentioned, might be lower than claims, and the data completeness threshold of for claims is 50% of all Medicare fee-for-service beneficiaries. Again, if you're choosing claims, you want to be sure in the specifications on the QCP website that claims are supported for the measures that you're choosing. Next slide. So the checklist, claims doesn't have a formal checklist that we could find, but we made one up just based on what we know about submitting via claims. You'll need to use software or have resources that make sure you understand the measure specifications. That's because there's very specific CPT codes and other codes that need to be paid attention to in order to be a successful reporter using the claims submission method. To reduce your reporting burden, only submit QCD codes. We suggest only submitting QCD codes for Medicare Part B beneficiaries. Always submit the QCDs with a line item charge of 1 penny at the time that the associated covered service is performed, since the submitting charge field cannot be blank. The beneficiary will not be billed for that charge, and EPs or eligible clinicians who bill nothing in that QCD line item will receive the denial code. Review your remittance advice or explanation of benefits. N620 is the denial code, and that's just an indicator that the QDC codes are valid for the measures. It does not guarantee that the data was correct or that the reporting thresholds were met. However, when a QCD is reported satisfactorily, the N620 can indicate that the claim will be used in getting you to that status, or in satisfying the claims reporting method. Claims cannot be resubmitted only to add or correct data, so you have to make sure that they are done correctly right from the start. And again, as I mentioned before, be sure that if you're going to report via claims that you make sure that the measures that you're choosing for claims are supported. So Lisa? Next slide. Oh, there we go. Thank you, Sarah.
Thank you. So the EHR data submission method specifications might be different for the same. This holds true for many of these reporting methods, that the specifications can be different for the same measure using different submission methods. So when you're looking up your specifications, make sure that you're looking for the type of submission you're doing. You can use EHR for group or individual reporting. You must use a certified EHR vendor, and you must report directly through your EHR using certified EHR technology. You should also check with your vendor to see which measures they are certified to report on, because every vendor is not certified for every type of quality measure. So many are certified for all, but some are not. Some are only certified for the numbers that you need to report on. So you've got to check with your vendor. And you can work with a third-party vendor to submit on your behalf through your EHR vendor. And you do need to have a data completeness threshold of 50% of all payers when you submit through your EHR. Next slide, please. So this slide checklist is from the group. This is EHR. I'm going to make sure I'm on the right slide here. Sorry. So this checklist is based on the steps needed to attest using an EHR. Well, CMS allows you to attest via EHR for ACI and improvement activities and quality. Not all vendors support reporting for all three methods. So we recommend that you work with your vendor to determine which categories they support. You should choose a CMS EHR, certified EHR, report the data, and work directly with your vendor. Next slide, please. So this, the qualified registries, I'm going to get onto these, sorry. Data submission, you should check with your, remember to check your quality specifications, as I said, may be different for the same measure using different submission methods. Groups or individuals can report via qualified registry, and the registry must be CMS certified and on the CMS 2017 qualified registry list. The registries are defined as an entity that collects clinical data and submits to CMS on your behalf. As with EHRs, check with your vendor to see which measures they're certified to report, or you can look on the CMS qualified registry list. The data completeness is the same with 50% of all payers. Next slide, please. This slide identifies the steps needed to attest using qualified registry. And again, you should check with your vendor if they can report for advancing care information, improvement activities, and quality. That is also on the list, on the CMS web list of registries. And the steps are to choose a qualified registry, determine how you will participate, choose and implement measures and activities, and report data based on participation level. And again, work directly with your registry to submit data by March 31st. Your vendors will need to do some things from their organization. They need to look at your Medicare claims to verify the group PIN combinations are correct on your submissions, and obtain consent from every clinician in your group to submit on their behalf, and you must transmit the data in the QTP data format of XML or JSON registry. And or JSON. The registry and QCDR SML formats are no longer supported. Next slide, please. And this is slide 20.
This is slide 27,
26.
Lisa. It starts with the qualified clinical data registry, or 26, yeah.
26. Okay, so this, the qualified clinical data registry is a QCDR. The data submission can include a combination of MIPS measures and non-MIPS quality measures. The first four bullets and the last bullets are similar to EHR and qualified registries in that the specifications can be different for the same measure using different methods. The groups or individuals can use this reporting method. You should only use CMS certified QCDRs, which are listed on their website, and you should check with the vendor to see which measures they are certified to report. And the last bullet is that you must attest to the threshold of 50% for all payers. The middle bullets explain the uniqueness of QCDRs, which is why they're kind of popular among associations and specialty groups. CMS defines a qualified clinical data registry as an entity that collects clinical data and submits it on your behalf. The key benefits include collecting clinical data for the purpose of patient and disease tracking, to foster improvement in the quality of care. Each QCDR provides tailored instructions on data submission for MIPS to CMS before they're approved, and QCDRs can support a combination of MIPS measures and non-MIPS measures. Next slide, please. This is the submission checklist, which is very similar. Choose the QCDR, determine how you participate, if it's test or partial or full. Choose your measures, activities, report the data, and work directly with your vendor to submit data by the end of March of 2018. And QCDRs have to make sure they have an EIM or Enterprise Identity Management account, and use Medicare claims to verify the combinations are correct, obtain consent of clinicians, and submit it in QRDA3 format or QPP data format, which is XML or JSON. Next slide, please. CMS web interface measures are, if they are not applicable to your patient population, or if you do not have at least 12 months of data for your Medicare patients to be used for assignment and sampling, it's advised that you choose another data submission method. Of course, this year the deadline was June 30th, so if you are registered for CMS web interface, it is required by advanced APMs and APMs. It eliminates the need to search for and select quality measures. You have 15 CMS web interface measures. Most of them match up with MIPS measures. You use 12 months of quality data on up to 248 Medicare beneficiaries, which CMS will choose the first 248 beneficiaries. And you're only it is the only reporting mechanism that requires annual registration in April through June, and ACOs do register on behalf of their members. Next slide, please. This measure specifications and supporting documents should be reviewed on the CMS specification sheets to ensure that the group will be able to report on each measure. Data can either be manually entered or uploaded into CMS web interface. CMS will calculate the reporting and performance rates, and you can choose to participate in CAHPS for MIPS survey. Next slide, please. And the CMS web interface measures checklist is to register before June 30th, ensure the group has the EIM account, use Medicare claims to verify, obtain consent of clinicians, and the submission period is January 22nd through March 16th, a little different than the others, and data can either be manually entered or uploaded into CMS web interface via XML file, which can be populated by a certified EHR. And the CAHPS for MIPS survey is a CMS-approved survey vendor that collects and submits data about the experience of care of the practice on behalf of the group, and the entire survey must be completed. Next slide. The survey checklist, registration is required, selecting a vendor, be responsible for your costs, and collect and report the survey. Monitor your performance during the survey, and receive your survey scores from CMS directly. And you want to have your CAHPS for MIPS survey scores available for public reporting on the Physician Compare website.
And Lisa, let's keep going. I think we should keep going because we've got a little bit to get through before we keep going for the Advancing Care Information data submission.
Okay, yes, that's right, I am on this one. So Advancing Care Information, sorry, I was ready to flip it over to you. Advancing Care Information submission methods can be done either through Qualified Registry, QCDR, EHR, or CMS web interface. Or you can do attestation on CMS website. The measures do not change for each submission method. Next slide, please. The two options for submission in 2017 are the Advancing Care Information Objective and Measures using 2015 certified EHR, or using the Advancing Care Information Objectives and Measures for 2017, which is using the 2014 certified EHR. There are 3 ways to earn points. To earn any points, you must earn the required base measures for a minimum of 90 days to earn any score. And then you have performance score measures, which are optional, bonus measures for up to 5 points, and bonuses for using the certified EHR for some of your improvement activity. This is the checklist for attestation of the advancing care information. How will you participate? Test partial year or full year, choose your measures, report the data. And there's vendor roles in there, again, verifying your claims, obtaining consent, and complete attestation. Next slide, please.
Okay, so now we're going to review I'm going to review a little bit of information about what we know about improvement activities data submissions. Next, here are the improvement activity data submission methods. We don't know anything more than you do today about how exactly that portal will look or how that attestation will take place. We have been told that we will learn more after the end of this year or the beginning of 2018. Next slide. This is a reminder. Improvement activities are weighted either medium, 10 points, or high for 20 points. Full credit is given to patient-centered medical home. Otherwise, you're submitting between 2 to 4 activities for 90 days, and those with special status submit 1 or 2 activities for at least 90 days. And in a partial and test mode, you're going to be submitting 1 improvement activity for at least 90 days. Next slide. Here is the attestation checklist for improvement activities. It's basically determining how you're going to participate. And this is both for improvement activities and advancing care information. You're choosing measures or activities for each of the categories, and then you're just reporting your data based on your participation level. Next slide. Just to review the MIPS scoring, next slide. CMS is 2017 is the pick your pace option, as it is the transition year. If you do nothing, you will receive a negative payment adjustment. That is not recommended because the first way that you can do is called the test phase. For quality, as you can read in the qualified fact sheet that was just published in August, you can submit 1 measure for 1 day for 1 patient, and that meets the test requirements for quality. For improvement activities in ACI, you must perform the activity for a minimum of 90 days. And for partial method, you can submit to all 3 categories for 90 days or more. And for a full, submitting a full year, you'll submit all 3 categories for a full year. Next slide. Here is the scoring for MIPS scoring. As we mentioned before, it's a 100-point composite score. If you achieve 3 points, which 1 quality measure for 1 day for 1 patient will get you to your 3 points. If you're 4 to 69 points, you will be eligible for a budget-neutral positive payment adjustment, and over 70 points, you're also eligible for an exceptional care bonus. So clinicians, basically, you're determining your eligible clinicians, your steps to success. You're determining which MIPS path you're on. Are you a MIPS clinician, or are you an alternative payment clinician? And then you're just deciding which pace you're going to pick. Of course, October 2nd was the last first day for the last 90-day reporting period if you hadn't begun to collect data before that time. And next slide. And so your steps to success, basically you choose your quality measures, choose your improvement activities, review your current performance, and then evaluate available reporting methods. Lisa?
Okay, so as many of you know, Stratis Health has developed a free tool to help you determine your baseline MIPS score and understand and use the tool to help you understand your score throughout the year. It's been available as an Excel file in the pre-release version. We've also been building it out to be an online application. We have built it out to be an online application, and this is a preview of what it looks like. So we're really excited that you can take a look at the MIPS Estimator tool. This is part of the home page. You can see the categories across the top, as well as the place to see your score as you keep moving through the tool. So across the top, there's each of the categories. The first one sets up your environment to set up your scoring, and then each of the categories brings you to the final score at the end. This is where it's available at www.mipsestimator.org. So this is just an example of a mock-up of a score that it shows that in the final page where the scoring is, you can see that, how the first provider, Candy, did in claims and how she scored with those very same numbers in registry and versus EHR reporting. And the second provider has different scores. Then you can see on the right-hand side how your group, how together those two providers performed, as a group. Next slide, please. From that, you can expand each of those areas to get the breakdown of how you did in each category of improvement activities, ACI, quality, and cost to come to your final score on the far right-hand side. And it shows the weights. I'm sorry, back up one. It shows the category weights in here. For this particular category, they're weighted at 15, 25, and 60%. MIPS APMs will have different weights. Next slide, please. Thank you.
Okay, so lastly, we're just going to review a couple of resources and tools slides. Next slide. Our Lake Superior role in the Quality Payment Program, as you know, is education and technical assistance. We also strive for physician and eligible clinician engagement, as well as beneficiary engagement. Next slide. So here's the LS QIN link, and then if you're looking for past events, you can see the second URL down there is for past events. There is the online MIPS estimator link. However, it has been posted to the LS QIN website as well, so you can see it there. And then we've just listed the benchmark table in case you're curious about how the quality measures are benchmarked. There are two more resources that have just become available that I wanted to make you aware of. First, the LS QIN has developed some audit readiness tools that include short recordings and a brief PowerPoint about audit readiness for QPP. While we haven't heard anything formal about audit readiness from CMS yet, but based on our meaningful use experience, we want you to begin thinking about audit readiness. So when CMS begins that process, you'll be ahead of the game. Those resources are posted to our LS QIN website, and they are under the Quality Payment Program. Again, the second resource that we just became aware of today is the QP, or the APM QP lookup tool. And we don't have a link to that since we were just made aware of it today, but it is at data.cms.gov/QP lookup. And again, we'll post that link to our website just very shortly in the next few days, I would imagine. Next slide. There are both help desks, both at CMS at the federal level. Could you forward next slide, please? Thank you. There are each of our states has their own help desk for QPP that we all man with subject matter experts, and then there is the CMS help desk, and those are just the URLs to those resources. Here's the link to the Quality Payment Program portal that I mentioned before. It's very rich with resources. And next slide. And then finally, here is our contact information for our 3 states. You will receive an evaluation as soon as you close out of this webinar, as Sarah mentioned before, and we really appreciate your input. And it looks like we have about 9 minutes for questions. And so, James, will you remind our listeners how they get involved to ask a question again?
Thank you. Once again, if you have a question, press *1 on your phone. And our first question here is from Catherine Olson. Go ahead, Catherine.
Go ahead, Catherine.
My question was, I have it written down here. Yeah, if a group is submitting as a group, but one of those clinicians was not actually eligible to report, but they submitted their numbers along with the group, does the payment adjustment for the group only apply to the eligible clinicians?
Oh,
The answer,
Lisa, and I can answer.
Oh, go ahead, Lisa.
I can answer that question. And yes, the group payment, the group gets the payment adjustment as a group entity, but it does not apply to that ineligible clinician type. Unless it's a low volume reporter, then it does apply.
Then it does apply. Because I think that was why I wasn't eligible. My billings were less than the 30,000 to be eligible.
And if you remember, the group gets the adjustment at the group level for all eligible clinician types because their number for eligibility is determined at the group level.
Okay, gotcha. So as long as it's okay, I got it now. Okay.
So this is Sarah. I just want to pipe in to make one comment, and that is that there were two different web addresses listed in the slide deck with regards to the Stratis Health MIPS estimator. It is mipsestimator.org, not .com. So if you go out to the Lake Superior QIN website, which is linked there in the chat box for you, there are links to a variety of different resources there, including the Stratis Health MIPS estimator and the Audit Readiness tool that Candy mentioned.
Okay, our next question is from Mandy Cherry.
This is Randy. That's okay.
Go ahead, Mandy.
This is Randy Terry. On the 50% completeness for the quality measures, is that completeness of patient or completeness of encounters?
It's 50% completeness of the eligible clients in the denominator. Does that make sense?
No. No, because I look out and I say, if I look at encounters, I get a different 50% completeness than I do if I look at patients for some of our providers.
So let's take a measure. I'm just going to take this off the top of my head, so I'm not following a specific measure specification. But let's just say the quality measure is about those folks who received the flu vaccine, for example. Your denominator is, of course, the number of people seen in that time period who are of that appropriate age who are eligible to receive that immunization. And so your data completeness threshold is 50% of that group that is eligible. Does that make more sense?
No, I understood it had to be all your quality measures and it had to come from your EHR that you had the 50% completeness measure, not necessarily within one quality measure.
So each quality measure...
one quality measure, yes. Every quality measure, you need to meet the 50% completeness.
Right, that's what I was just going to say.
Okay.
Lisa, did you have anything to add to that?
No, it's basically by quality measure and it's by beneficiary.
Okay, our next questioner did not leave a name, so questioner, please give us your name. Could you unmute your line, perhaps? And once more, you're the only questioner in our queue, so if you hear me talking, I'm talking to you. Okay, we have no other questions at this moment.
All right, Sarah, are there any questions in chat?
I'm not seeing any questions in chat at this time.
All right, well, if we... Oh, go ahead, James.
No, I was just going to say, yeah, if you have a question for the phone, just press *1. And we have no questions.
And Randy, maybe we can touch base offline too to spend a little more time with you understanding that data completion idea. So.
And this is This is James again. We do have the questioner back.
Okay.
So go ahead, please. State your name.
I have a new question. My name is Lois Sapral. We have a new grad that has passed her NP boards and will have her Medicare billing access by November 1st. Is she exempt from reporting?
Yes, because she's new to Medicare in this performance year.
Okay, thank you.
And she will be eligible to report next year, though, because that would be her second year.
Okay.
And we do have another questioner, not leave their name. So, questioner, please state your name.
Anne Lean.
Go ahead.
Hi, Anne.
Hi. My question is, could you clarify critical access hospital and I need to get a signed permission from all my eligible providers to submit on their behalf, whether it's individual or group? Is that correct?
Yes, that is recommended.
No. Oh, that is recommended. Sorry.
That is on the checklist for all submission methods to get signed consent for if you are submitting to MIPS on someone's behalf, you should get a signed consent form from them.
Okay, is there a standard form or we just basically have a simplified statement?
Just a simplified
Keep
statement.
that on file.
Yes.
Okay, thank you.
We have received a couple of questions in chat, but I see that we are at the end of our hour. So what we'll do is we will jot those down and get in touch with those individuals directly to answer your questions. Remember, as you close out of today's webinar, you'll be automatically redirected to an evaluation, and we ask that you take a few minutes to give us some feedback. Upon completion of that evaluation, you will get a certificate of attendance for your records. Thank you, everyone.
Thanks, everybody. Thanks for attending our webinar today, everybody. Talk to you all soon.
Bye.
Thank you, ladies and gentlemen. This concludes today's conference. Thank you for participating. You may now disconnect.